Welcome to Medication Talk, the official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, RX Advanced, and the most trusted clinical resources. On today's episode, listen in as our expert panel discusses pharmacotherapy for managing generalized anxiety disorder and major depression, with a focus on tailoring first or second line options to individual patient needs. Our guest today is Dr. Marshall Cates from the McWhorter School of Pharmacy at Samford University. You'll also hear practical advice from TRC Editorial Advisory Board member Dr. Craig Williams of the Oregon Health and Science University. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate evidence-based practice recommendations. The full webinar originally aired on May 16, 2024.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, physicians, and nurses. Please log into your Pharmacist Letter or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. For the purposes of disclosure, Dr. Cates reports relevant financial relationships by receiving an honorarium from Biogen and Sage Therapeutics and participating on a speakers bureau for Otsuka. The other speakers you'll hear have nothing to disclose. All relevant financial relationships have been mitigated. Now, let's join TRC editor, Dr. Jeff Langford, and start our discussion.
We're talking about these topics now because mental health concerns remain front and center for many patients and clinicians. In fact, there was a recent patient-based survey reporting that 2/3 of adults have experienced concerns about their own mental health or the mental health of family and friends. And this represented an increase of about 15 percentage points since 2020, during a time we were already recognizing increased mental health concerns due to COVID. With that context, let's start by considering anxiety disorders. And these are common, often under-recognized and undertreated, and represent really a spectrum of conditions ranging from generalized anxiety disorder to social anxiety, panic disorder, and phobias. And while they are diagnostically different, there are commonalities across these different disorders, including feelings of anxiety, fear, nervousness, and worry. But where we're going to hone in and kind of drive our discussion today will be around generalized anxiety disorder. And Marshall, I'm wondering if you can help us get started by kind of painting out the picture of generalized anxiety disorder, what that looks like, and how it differs from common feelings of worry or anxiety that most of us deal with from time to time.
Yes, thanks, Jeff. Worry is just part of the human experience. We all experience it. Generalized anxiety disorder, though, it goes beyond normal worry. For one thing, normal worry is really usually very specific and limited about what the individual's worrying about, whereas in generalized anxiety disorder, there are numerous issues that the person is worried about. So it's excessive anxiety and worry. It's also, in generalized anxiety disorder, very persistent. So according to DSM-5 criteria, those symptoms have to last at least 6 months. So very, very long as opposed to a short duration of normal worry. In generalized anxiety disorder, you see individuals with a lot of significant subjective distress and or an impact on their functioning. So the worry and anxiety is really having an impact, whereas normal worry, that's not the case. One other very important aspect is, can you control it or not? In normal worry, an individual typically can, whereas in generalized anxiety disorder, they can't. So one of the things I like to ask patients is, if you're getting ready to watch your favorite television program or do something for fun, can you turn off the worry? And if they can't, it's more likely to be GAD. And so also in generalized anxiety disorder, there are additional symptoms. 4 of those are concentration, insomnia, muscle tension, restlessness. There's a few others like irritability and fatigue. But those are the main differentiating factors between normal worry and generalized anxiety disorder.
Okay, so once we have a patient that has been diagnosed with generalized anxiety disorder, we can really kind of picture 2 potential treatment pathways in terms of initial options, and that might include psychotherapy like cognitive behavioral therapy, or it might be a medication treatment path using agents such as SSRIs. And without necessarily getting into the details of those different options, but just considering those two broad pathways, Marshall, what might tip the scales to one path or another for you? How do you tailor that to your individual patient?
Well, I think in large measure, it has to do with what the patient wants. Because as you mentioned, you can really go either route. Psychotherapy, it's not available for everybody. It kind of depends on where they live. So it might be unavailable. It might be unaffordable. Some of the medications first line medications are actually very inexpensive. So I think psychotherapy, like cognitive behavioral therapy, is very good. Some patients prefer that route. Some patients prefer meds. And of course, in severe anxiety, you might want to use a combination of those.
Okay, we're going to drill in or focus in on the medication pathway for purposes of the discussion today. Our first line agents include SSRIs or SNRIs. Some second line select choices that we could consider include buspirone, pregabalin, hydroxyzine, or the benzodiazepine class. And I'd like to talk a little bit about considerations with these different agents. Our article on this topic started with a recommendation to consider SSRIs or SNRIs first line based on overall evidence for generalized anxiety disorder. And I wonder, to start with, Marshall, do you align with that recommendation? And if so, maybe unpack a little bit of what we know about the effectiveness there.
Yes, absolutely. I definitely agree that those are the first line medications. Several of those medications in both classes are FDA approved. We know that these medications are very effective. One of the real advantages of using SSRIs and SNRIs is that they also address the comorbidities that are frequently seen with GAD. So some of the other anxiety disorders, you mentioned panic disorder, social anxiety disorder, as well as major depression, which is comorbid. So you can use these medications to really hit all of those. There are some disadvantages, all those medication classes that you mentioned earlier. This is the class that cause sexual dysfunction to a fairly great degree. There's a slow onset of action. So just like when you use these medications to treat major depression, there's at least a few weeks lag time. It may take 2 to 3 months to really get the full effect of medications. Part of the issue also is dosing. So you typically start at a lower dose with these medications so as to avoid what we call the jitteriness syndrome. These patients are already anxious, and so you typically start off at a lower dose, but the dosage range that you use is very similar to what you use in major depression.
Well, I think a question that often comes up, especially for our primary care prescribers and our pharmacists on the front lines, we recognize or may recognize that these agents are first line, but how do we pick within these classes? There's so many agents in both groups. Do you have a go-to, Marshall, within these classes?
Well, for one thing, you're right. I mean, there's a lot of different medications within SSRIs and SNRIs that you can go with. So as a clinician, how do you select one for another for a particular patient? And to me, you really look primarily at side effects and also potential for drug interactions. So even though, for example, you have 5 SSRIs that are typically used, and they have this sort of common pharmacologic action of serotonin reuptake inhibition, they also have some subtle pharmacologic differences that really translate to different efficacy and different side effects for a particular patient. So, for example, sertraline is a little bit more likely to cause gastrointestinal side effects like nausea, diarrhea. Paroxetine is a drug that it's got some anticholinergic properties, so it might cause more sedation, anticholinergic side effects, weight gain. Fluoxetine and even sertraline can be more stimulating. And so there's these aspects. The SNRIs, both venlafaxine and duloxetine can cause increase blood pressure. But one of the differences between them is that duloxetine can have some hepatic effects. And so if you have someone with a pre-existing liver disorder or maybe a heavy drinker, alcohol drinker, you might be better off going venlafaxine. The other thing that I mentioned was drug interactions. So paroxetine and fluoxetine are strong inhibitors at cytochrome P452D6. Duloxetine is a moderate inhibitor of that isoenzyme as well. So you can look at various factors and try to figure out, maybe there's one that you want to rule out or one that's better for a particular patient.
I agree with everything Marshall said. These absolutely are our first line drugs with SSRIs and SNRIs, and I also don't have a real reason to prefer a class or a particular agent. But I think a lot of us who deal with this a lot kind of in the primary care angle see these as first line because they're also much better tolerated and generally safer than other things we'll talk about from a risk-benefit standpoint. And I'll just add too, or talking about that, we're kind of fully prepared these days for patients maybe not to respond great to these medications, depending on how severe their anxiety is. Sometimes patients respond well, and that's great. But sometimes they don't, and that often kind of fits the literature where the benefits really are fairly modest. And you can find negative studies of both SSRIs and SNRIs, even among the data used to approve these drugs, these indications by the FDA. So I think mixed bag, but definitely from a risk-benefit standpoint, definitely our first-line drugs.
Great perspective there, Craig, and I think that's going to be a nice segue as we talk about second-line options. Our article goes next to buspirone, saying to consider it if an SSRI or SNRI isn't tolerated or as an add-on if they aren't enough. And Marshall, I'd like to start with you and just ask about perhaps some of the pro-con considerations that you would have around buspirone.
Yeah, so buspirone really sort of has, I guess, a reputation of perhaps being less efficacious. There are inconsistent reports of efficacy. Probably some of that's not that well deserved, and I'll talk about that in a second. One advantage of buspirone is that it doesn't have any abuse potential. It doesn't have any physiologic dependence or withdrawal like benzodiazepines. But it also, unlike SSRIs and SNRIs, it will not treat the common comorbidities of GAD, so other anxiety disorders and major depression in particular. It also has a slow onset of action, just like antidepressants. It takes about a few weeks to really start seeing effects. Generally well tolerated. Some patients can't handle particularly the dizziness and the nausea. But the dosing aspect, I think, is part of what plays into this perception of lack of efficacy. Clinicians tend to start at around 10 to 15 milligrams per day, divided BID or TID. It's got a short half-life. But the effective dose might be anywhere from 30 to 60 milligrams per day. So as a clinician, you really have to stay on the titration unless they just simply can't tolerate the drug. So I think that's part of what plays into the inefficacy, because when I see it used, it tends to be relatively low doses.
One more point on buspirone before we move to the next drug option, but you mentioned dividing the dose BID or TID, Marshall, but I wanted to emphasize that it should not be given PRN. There's no rule for buspirone to be used PRN, and I think people still perhaps see that crop up every now and then, and I think that would be an area where we'd need to make a recommendation for a therapy, a different dosing plan. Do you agree with that?
Yeah, absolutely. And, you have to understand, buspirone really kind of came on the heels of a lot of benzo use, right? And so people were trying to use buspirone like they were using benzodiazepines. And I think that's part of why it does have a reputation for limited effectiveness. People don't get the same feel, if you will, particularly physical symptoms when they take buspirone compared to previous benzodiazepine therapy. And the same thing with as needed. I mean, you can't take this drug as needed.
Okay, let's talk about pregabalin for a minute. In our article, we said to think of that as an alternative or an add-on for generalized anxiety disorder. I think this drug also comes with a fair amount of baggage, at least in terms of perception, Marshall. And can you walk us through perhaps the considerations that you would really have in mind before you're choosing to use pregabalin for anxiety?
Yeah, pregabalin to me is a drug that the evidence base doesn't match the use. Pregabalin is not FDA approved in our country. However, it's been used for a long time and it's approved in Europe. So I think they use it a lot more for generalized anxiety disorder than we do. But there is a fairly robust evidence base, double-blind randomized controlled trials showing that pregabalin works. It does have an anxiolytic effect. So it appears to be as effective as, our established drugs based on the evidence that we have. One interesting thing is that it has a relatively rapid onset. So I think the literature points to about a week, which is not quite as quick as benzodiazepines, but certainly quicker than antidepressants and buspirone. There aren't much data, though, on whether or not it can address some of the comorbidities we've talked about, some of the other anxiety disorders. There's also some concerns for abuse. It is a Schedule 5 medication. So remember, benzodiazepines are 4, but this is a 5. And I think one of the interesting aspects of this particular drug is that it's renally excreted, and so if a person has some renal problems, that's something to take into account in dosing. But the flip side of that is that it's a really low risk of drug interactions as well. Adverse effect, it's tolerated okay. It can cause some dizziness, sedation, weight gain. There are also some peripheral edema. So something to think about. One other point I would make, like duloxetine and venlafaxine, this drug can also be used for those with diabetic neuropathy. So you can kill two birds with one stone.
Can I add or ask Jeff while we have Marshall? Interesting to me that we're talking about pregabalin without gabapentin, because the gabapentinoid's pretty similar if you control for dose. But does Marshall know, is gabapentin not approved or used in Europe? And I'm not used to really either of these for anxiety in our population.
Well, and that's because a lot of people really don't use pregabalin. And I think the opposite is true with gabapentin. You have quite a bit of gabapentin use, but the evidence base really isn't there. So unless one is really willing to, because they do fall in the same class, they do have similar pharmacologic mechanisms, unless you're willing to generalize the literature that we have with pregabalin to gabapentin. I have never really been that impressed with gabapentin's tolerability, particularly as one goes up on the dose. But I think sticking with just evidence base, I would go with pregabalin over gabapentin.
Yeah, and just back to our earlier point, we're definitely kind of moving into these drugs, definitely not the same safety profile we have with the SSRIs and SNRIs, but obviously gabapentinoid's approved as anti-seizure medications, and they are by design CNS depressants. In a way, not surprising, at the right dose, they might have some anxiety benefits.
Okay, those are great points. I do want to move to benzodiazepines next. Our article advised saving benzodiazepines as an add-on or for just a few weeks until an SSRI or SNRI starts working, or for severe anxiety disorders. And to start with, Marshall, wondering if you agree with that place in therapy?
Yes, I do. Okay. And, from a historical perspective, remember benzodiazepines used to be the gold standard for treating generalized anxiety before antidepressants took over. But, you do have to worry about abuse issues. We've already talked about that, and physical dependence and withdrawal. And that's the only reason these are second line. I mean, they work well. They work really just as well as antidepressants, but they will not work for comorbid depression, obviously. I think, where benzodiazepines really come in, where I see it come in even more so than add-on, although you can certainly see that, it's for bridge therapy, which is what you referred to. You take advantage of the fast-acting action of benzodiazepine. So you start an antidepressant and the benzodiazepine at the same time, and then after a couple of weeks, taper off the benzodiazepine. That way, you get through sort of the lag time for onset for the antidepressant, but you're not using benzodiazepines chronically, which is where you can get into some of the problems. So bridge therapy, and also in patients who have failed multiple other drugs, you can see monotherapy with benzodiazepines or add on to the antidepressants in particular.
But if we're seeing it used long-term in patients, you would really see that being a patient that has not responded to multiple other regimens that we have done all the right things with in terms of dosing and optimization before we moved to long-term use of a benzodiazepine.
Yeah, I think you would, according to the guidelines, you would really want multiple trials of the first line drugs before you move to any of the second line drugs. I think that's definitely true.
Okay. Yeah, Jeff, I think that's absolutely right pharmacologically. And we do sometimes find ourselves having discussions with patients where it is getting into more chronic, or it's becoming more of the conversation, that reminding them the goal is overall to help the patient be more functional in their life. And so you can get into some nice conversation with them about kind of overall goals. And if they're just using benzodiazepines and not kind of becoming more functional what they want to do, that we're not helping the patient move their life forward. And that's often what's happening when you get into chronic use of these medications. So.
Yeah, and if I could add one thing, I totally agree with Craig on this. And one mistake that clinicians sometimes make is they don't have the conversation with patients up front about how long they can expect to be on benzodiazepines. The last thing you want to do is have a patient do very well, feel very well on benzodiazepines, and then several weeks later you say, oh, by the way, we're going to start tapering this off. That conversation usually doesn't go well. So always address the expected duration right up front. I would say that with all psychotropics, but particularly benzodiazepine.
Well, let's turn now to depression and management of depression. And Marshall, just like we started our anxiety discussion, would like you to walk us through how major depressive disorder differs perhaps from common feelings like sadness or blueness that many of us experience.
Yeah, and it's very analogous to what we talked about before. Feeling sad or blue is just part of the human experience. Major depression is a whole other level. It affects not just mood, but the way people think, their physical health, their ability to work or go to school, their relationships, a lot of different things. The diagnosis for major depression requires persistent symptoms, so at least 2 weeks. Symptoms can last months, and in rare cases even years if you don't treat it. There's also a number of symptoms. There's non-diagnostic symptoms. Someone has to have at least 5 of those, including one of those must be depressed mood or anhedonia, which is a loss of interest or pleasure in activities. And I think one of the major things is that you either have to have clinically significant distress, or the individual has some impairment in their ability to function, whether that's socially, occupationally, or some other way. So these symptoms translate into impairment or distress.
Okay, and for the patients that we have meeting that criteria, we're going to see a similar treatment path, at least initially, with psychotherapy being an option or select medications being an option. And with that thought, I'd like us to spend our last block of time talking about first-line medications for depression, really in the SSRI, SNRI bucket, or bupropion or mirtazapine. And I want to really tackle those kind of one by one and ask each of you to share some thoughts on patients that you might prefer that drug or class for, as well as patients that you might use it with caution in or even steer away from using it altogether. So let's start with the SSRIs, Marshall, and I'll ask you to kind of tackle that class and share some times you might use it, times you might avoid it.
Yeah, well, the point that Craig made earlier, I mean, these drugs, clinicians are very well versed with these drugs. They're familiar with them. They know how to dose them. They're familiar with the side effect profile. So these are crowd favorites. They do cover comorbid anxiety disorders as well as a host of other disorders. But the one thing that I definitely want to highlight is the potential for sexual dysfunction. It's so frequent. And, I used to joke that I ran a clinic one time, and I called it the antidepressant-induced sexual dysfunction clinic because there were so many patients on antidepressants, and I'd say at least a third of the patient, the incidence rates on this they're all over the place in terms of different studies, but my take is probably about a third of patients have significant sexual dysfunction with SSRIs, and it's something you want to tackle up front. Is that possibility? I mean, you can manage it on the back end, but you definitely need to mention this to patients. But it's a great class of medications. That's why we use them so often.
Craig, as we look at the SNRIs, anything that kind of jumps out at you as being important factors in your mind when you're considering when or where to use these?
Yeah, I think generally speaking, very safe drugs that, as Marshall alluded to, we have a big comfort level now with using this class as well as the SSRIs. But, the N is norepinephrine, and that does bring along some different effects. And the kind of agitation, which often is more subtle, but they definitely have a bit more stimulant effect, and the hypertension kind of comes along with that as well. So, in terms of choosing, it'd be more, do I have one of those things to think about I want to avoid?
And to just reiterate a point I made earlier, the other thing I'd say is duloxetine with liver disease as well. I try to avoid duloxetine. And then both with SSRIs and SNRIs, there are particular drugs, paroxetine, fluoxetine, duloxetine, that can have some significant drug interactions.
Very good. Well, let's look at the other two classes, and we'll kind of take these in together for sake of time, but bupropion and mirtazapine as far as two additional agents that are first line. And you mentioned agents that we might consider with sexual dysfunction, and I wonder if you can kind of unpack both of those for us, Marshall, and how they might be preferred for patients if sexual dysfunction is a concern, and in any specifics that are really top of mind with either of those agents.
With bupropion and or mirtazapine?
Yes, yeah.
Okay, yeah, I think that bupropion probably even has less sexual dysfunction than mirtazapine. They're different mechanisms. You have to remember bupropion is the only antidepressant that we have that has nothing to do with serotonin, right? So you don't really see sexual dysfunction. Mirtazapine blocks serotonin 2C or 2A receptors, and that's how it supposedly has decreased sexual dysfunction. But both of these drugs are good for that aspect. They're really kind of opposite in that bupropion is a more stimulating drug, though, and so it might cause anxiety, it might cause insomnia, it might cause weight loss. Mirtazapine is the opposite, right? It's sedating. It can cause weight gain. And so I think about mirtazapine in patients that are having trouble sleeping and maybe they've lost a lot of weight while they were depressed. But definitely avoid it if they're already overweight or obese, or they have diabetes or prediabetes or something like that. And of course, bupropion, you have seizure disorders is a contraindication, but even those things that can play into seizure disorders, like a significant history of a head injury, or somebody that has anorexia or bulimia and accompanying electrolyte abnormalities, that's not a good drug to choose.
Okay, well, with those thoughts in mind around picking that first-line agent, I think it's really important for us to set the stage with our patients that trial and error may be involved in this process. Less than a third of patients are going to achieve remission with the first antidepressant, and that can really lead us down a couple of different pathways. The first might be switching agents for patients that have either no response or perhaps intolerance, and in that case, we might choose to use a different type of antidepressant or potentially switch to another medication within the same class. The other possibility would be patients that have a partial response, and I'll get your thoughts here, Marshall, around augmentation. If a patient has a partial but incomplete response and we need to consider augmentation strategies, what are the things, your primary go-tos for augmentation if needed?
The FDA approved route is to use second generation antipsychotics. So there are several that are indicated for this, such as aripiprazole and brexpiprazole and cariprazine and quetiapine. You can combine with a second antidepressant. I would say this is, they're both frequently used. Clinicians tend to prefer one over the other. But if you're going to add a second antidepressant, as we were talking about earlier, it's not absolutely wrong to use an SSRI with an SNRI, but usually you add in a drug like mirtazapine or bupropion to one of those because of the taking advantage of different mechanisms. In terms of the classic drugs that we can combine, the one on there that I prefer is actually buspirone. I like to augment with that.
Great. Well, that gives us several different strategies and some kind of pros and cons to keep in mind with those.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, physicians, and nurses can receive CE credit. Just log into your Pharmacist Letter or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. You'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools, from the Pharmacist Letter and Prescriber Insights websites. If you're not yet a Pharmacist Letter or Prescriber Insights subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find this show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.